Good afternoon, everybody. My name's Emma Brooks, and I'm the head of Soft FM Strategy and Operations for NHS England. I'd like to thank you for joining me to talk about the National Standards of Healthcare Cleanliness and the journey so far. You will notice we talk a lot about cleaning as a science, the power of partnership, and cleaning for health, because they are all the elements of how the document was made up. I apologise, I have a tendency to roam, so if someone can wave at me madly if I walk too far away from the microphone and you can no longer hear me, unless of course you prefer not to hear me. So I want to talk a little bit about our challenges, the environment in which we're working in, that makes all of the standards that we do at the centre so important. We know we've got a fragile market. We know we've got workforce issues, and trying to do things properly, we need the right workforce to do that. You know, we call it EU exit. That was a while ago now, but it does still have impacts along with other global issues. We know there has been in the past a variability in the cost and the quality of services that trusts are offering or healthcare organisations are offering. We know that there is resource issues, constraints. We've got inflation going up at a mad rate at the moment. All of these things are competing alongside, you know, the medical care and everything else that we need to do on a daily basis to keep our patients safe. We've got driving through a digital agenda, which can be supportive, but also there's a lot of work in the background to make that happen. And we know we've got the ever-changing NHS landscape. Somebody once told me if you stay in the NHS long enough, all of the ideas that were there when you first entered the NHS will come back round again in a slightly different badge. So this is a little bit about the size of the task we're looking at, so some cleaning numbers for you. We've got more people sleeping in our beds each night than there are hotel rooms in London. And bear in mind, this is just England. This isn't the whole of the country. It's not 4 nations. This is just England figures. We clean an area the size of London almost 4 times a week. We're using enough energy to power up over 200,000 homes. We have 1 whole-time equivalent cleaner to every 3.4 beds in England, and we've got 40,199 whole-time equivalent cleaning staff, which is equivalent to the number of runners in the London Marathon. So there's a lot of stuff going on behind that. So I want to talk a little bit about the journey. This was a bit of, to quote Donna Brown, who some of you may have caught her excellent piece on the research they're doing into cleaning as a science. To quote her, this has been, is and continues to be a labour of love. We convened a working party in December of 2017. We started to run pilots across October 2018 through to January 2019. We started from a place where we looked at what had come before, so the 2007 standards, and we also looked at some of the other standards that had come out during that period, like the PAS specification for cleaning. We tried to take the best of both, and we looked at PAS was designed very much to be flexible for organisations and assess not just your clinical risks, but also the risk to reputations about areas being clean, not clean. And things like that, where the infection risk might be low, but the actual, perception of someone walking into that organisation would cause issues. And with that, we started to look at the sort of traffic light system that they used, red, amber, green. And as we found from the pilots, people really hated that because especially our clinical colleagues could not understand why anything wouldn't be in that sort of red area. So you'd be cleaning the entire hospital and auditing it, at a very, very high rate. So we had to look at that. We worked alongside 30 trusts across England and Wales. We also had a couple of hospices, a GP surgery, and various different settings as we looked and worked through this. And we got data back from those 30 organisations, which helped us to shape and amend what we were doing. You know, the whole project spanned a total of 4 years, so there was a lot of work reviewing what we'd looked at, going back to organisations, as well as then sending it out to all organisations and getting comments back and being able to feed back on that. So in the end, in May 2021, we were able to launch the new standards. There was a period of compliance for that. We didn't just launch them and say now everybody's got to do it. We started to work through a period of compliance, which was 18 months in total. So as of 4th of November last year, all organisations in community health, mental health, acute settings should all be now compliant with these standards, including secondary dental or anything like that that is within hospitals. We continued to run webinars, do local central support. We've been out on a number of visits to support trusts where they might have been struggling to understand things. And that is ongoing, it doesn't stop. We don't deliver standards and walk away. We continue to work with organisations. It's very important for us that people understand this is a journey. There is no mechanism in this for trying to beat up organisations where they might be struggling to get something right, where they maybe need longer because of financial constraints or any of those things. The idea is that we get all healthcare organisations up to the same minimum standard. It's an opportunity, it really is an opportunity for organisations to look at how they do things. We've done things in certain ways for so many years, this is a good opportunity to look differently. A good example will be most organisations, any cleaning above hand height becomes a hard FM issue. So that means you'll have an electrician or a builder or someone doing that cleaning. Now, number one, any of you who have ever seen a builder's clean knows it's not the best clean in the world, and they're not experts at it. They also have much smaller teams. So let's think slightly differently. Can we upskill our domestic staff to be able to know how to take that light fitting down and clean it, or remove a radiator cover to clean inside that and clean the radiators? It's about thinking very differently. We ask organisations to look and say, just because we've always done it that way doesn't mean we should necessarily continue to do it. Now, in some organisations, that partnership works incredibly well, but not in all organisations. Clinical-led cleaning, for example, we know time is stretched. And actually, we are healthcare cleaning professionals. We don't go around trying to put cannulas in patients. So actually, perhaps cleaning should be down to those people that are experts in what they do. So I'm going to talk a little bit about the actual document itself and the ethos. So this was where we started from. It's got to be done collaboratively. Cleaning is everybody's business. It isn't just down to one domestic on a ward. It's everybody's business. You know, if you step over a tissue in the corridor, every day, then it's actually your business to pick it up, not look for a cleaner to do it or wait for somebody else to do it. It is everybody's. And I do mean from the chief exec all the way down through everybody, it's everybody's business. We want transparency and assurance. I'll talk a bit more about the auditing and the efficacy in a minute, but it was about giving organisations that ability to be able to say, we have assurance that the processes, the frequencies and everything else we have actually do work to make sure that the environment is clean and safe for our staff as well as our patients and our visitors. Infection prevention and control. We know all of this goes hand in hand. We can't, keep everything clean and safe without the support of infection prevention. And you guys need our support in order to be able to make sure that the environment remains safe and clean for everybody. We've also got continuous improvement. Now, I know a lot of people don't like this term because eventually you should get to 100%, and therefore what's left to improve. But actually, we all know it is an ever-changing landscape. There are new bugs, new organisms, new things coming out. There's new technology that supports the way we clean. There's new chemicals. There's new ways of cleaning. So there is always, always room to improve. So This is, hopefully, you've all seen these up in your hospital. Every patient-facing area should have cleanliness charters. So these were designed on the premise that the previous standards said that we should be displaying the work schedule. But as we all know, when a cleaner comes onto the ward at 7 a.m. in the morning, there might have been discharges overnight, something's happened. The schedule says they should be cleaning the toilets at 7 a.m., but they've been pulled away to do some bed cleans because we need the space, because there's patient waiting in A&E to come up. So already they've failed because they cannot do what we've said they should be doing at that time. So what we looked at was, what do people need to know? What you need to know is that the toilet in your area is being cleaned once a day, twice a day, 10 times a day, whatever it is. You need to know whose responsibility that is to clean that item as well. And the summary is all about, we've all got a part to play in this, even patients and visitors. You know, accidents happen. If you have an accident, tell us, we can fix it. If it's a toilet, stop somebody else from walking into that. And it's the commitment of organisations, and it's something that should be, it's our brand, isn't it? We should be very proud of our brand, the NHS. So this is something that should be seen in every single healthcare organisation, which allows patients and staff to feel better. It translates information. If you're moving around from trust to trust, if you're an agency member of staff, you will see these same things. So that moves on to star ratings and auditing. So star ratings are what we kind of called the Marmite of the cleaning standards. People either love them or hate them. But the idea is it shows that transparency, it gives assurance. It's easy for people to understand. It's very difficult under the old standards where we were displaying percentages for a patient to understand why they're sitting in an area that says 85%, which is significant risk. So well, that's green, happy days, we've met what we needed to meet. But to a patient, they might be sitting there thinking, well, am I in the 15% of the ward that isn't clean? And that's not what we're saying at all. We know that, but it's making it easier. It's also translating that into something that we can be proud of as well, and that is displayed easily and nicely. So on top of that, our normal audits that are now translated into star ratings, we have the efficacy audit, and this comes back to giving you more assurance. We have done visual checks for a long time. Since 2001, visual checks have been there. But that is only telling us that it looks clean. So for example, if I pick up one of these glasses here and spit in it and then wipe it out, any one of you in this room coming and doing a visual inspection will say that is clean and you'll pass it, but it's not. So it's not, we know it's not easy to see everything. So what we need to do is assure ourselves that we are training our staff properly, that we are using the right equipment, the right chemicals, and the right method of cleaning. We're not taking a microfiber cloth and sort of wiping the inside of the toilet bowl and then going and wiping the sinks or down a patient table. So that gives organisations much better transparency and understanding that their processes are more assured. So I'm not going to talk through this, don't worry, and don't try and read it. It's just a bit of a highlight. I'm sure all of these slides will be shared with all of the delegates, but essentially this is just showing how percentages within functional risk categories translate to star ratings. So this is quite an exciting new adaptation to the cleaning standards. Many of you who might have been around for many, many years may remember back in the 80s there was a proper cleaning manual. It was a book, it had lots of great photos, and you can really date it back to the 80s if you read through it now, because you can see the outfits and the mops and buckets they were using then and things like that. It has been updated, but for many years it's just been a very dry list of, you know, pick up this, put that there, move this there. And in reality, we're probably not going to get the people who need to know this stuff to sit down and read that. Those things are still there, sitting behind all of these, because it's important for managers, for supervisors, to perhaps who want to go into a bit more detail. But what we have is these lovely posters, so they can be printed off and put up. They can be printed off smaller and used as your own manual that you can put together. But each of these posters has a bite-sized training video that goes with it. So you can get your staff into, in front of a computer. You can get them to get it on their smartphone, and they can do these bite-sized bits of training. You can use it as a full training program throughout your organisation. There are currently about 48 of them, and they sit on the NHS Futures platform. So if you've got an NHS address, you can get on that. And there's also lots of other information there, but you can have access to all of the videos, all of the posters. It's all free. There's nothing to pay. So they are all there. So what's next? This is great. 2021, we're now in 2023. What is next? So at the moment, many of you may be aware that those standards didn't apply to ambulance trusts, because when we got to the launch point, it was apparent more work was needed for that group and that sector. So my colleague Phil Shelley has been leading a working group that has working with a large number of ambulance trusts. It's just getting ready to go out to consultation with all ambulance trusts now, and should be available later this year. Again, there will be a period of compliance, but it also brings on board additional cleaning standards for things like vehicles and premises that are very bespoke to ambulance trusts. There are also some areas that are missed out. So whilst they will have to have their cleanliness charters, we're not expecting them to put them in the back of an ambulance, because let's face it, if you're in the back of an ambulance, you probably don't care. You're not going to be sitting there reading that. So, and equally, we'd do a lot of littering if they went on the side of the motorcycles. So, there are some bespoke bits for those areas. They've got slightly different auditing and governance, how their vehicles come in and out of hospitals when they're going back to base. So there are some things, including the training and methodology and sort of specialist deep cleaning areas. So look out for that if you're in an ambulance trust, was the point of that. Primary care work. So you've probably heard a lot of people talk today about, how a lot of things appear to be acute focused or hospital focused. And what we wanted to do was develop standards that really do cover healthcare. Because actually, if you're sitting in a GP surgery that isn't getting cleaned to the correct standards, and you pick something up and your GP sends you to hospital, that's coming into our hospitals. So actually it should be the same standards and the same methods along, with some tweaks. It's a bigger project, I'll be honest, working with primary care, and obviously all of the different organisations, from massive health centres all the way down to sort of like one doctor GP surgeries. And we are working alongside the integrated care boards, CCGs, the GP provider networks, and a whole wealth of people to try and get the next element of this out and start to bring our other healthcare partners up to speed in primary care. It's ongoing work. It is likely that there won't be anything launched until, and I think this does say 2023, but it is likely to be close to 2024. So if anybody does work in those types of settings and wants to get involved, please do feel free to contact us at the centre. So Exemplar Trust, it's actually Exemplar Site, and what we've been doing, this started off the back of food. We've been working with a number of trusts. We now have 20 odd trusts that are Exemplar sites for food. We have 4 for cleaning at the moment, but obviously we're accepting applications, and 1 for portering. We have 1 site actually that has a total FM Exemplar site status. That status stands for 2 years, so we don't just give it and walk away. And it's not about getting every little thing 100% right every single day. What it is about, ensuring that your standards are implemented. It's ensuring that you have a whole organisation approach, ensuring that you challenge us at the centre about things as well, but equally we can challenge those sites to trial things, test things, pilot things where we need to. The idea is that over time, we will have at least sort of 80 exemplar trusts or exemplar sites across the piece, and that will support the work that we do. So we can, if a trust is struggling, we can buddy them up with a trust that has exemplar site status, so they can work with them to see how have they managed to achieve this, how have they managed to do what they're doing. We have a process out there for derogations of the cleaning standard, or temporary derogations, I should stress that. All of our ones that came on board prior to our implementation dates are now off derogations. They've worked with us, they've worked through their action plans. We have had a couple of very late applications through, and that's okay. What we want is for people to come to us and say, I'm struggling, I don't know how to do this, or I've got some financing issues, or whatever the case is. It's much better that we know and we can work with organisations than wait until the CQC walk in or we visit or anything like that. It's better to flag it with us so that we can work through. Okay, so a little bit about Royal Surrey. They are our first and only currently full FM exemplar site. But a bit about their cleaning. The reason they were our first one to come on board as a cleaning exemplar site, and some of the lessons that they learned through that thing, why it went so well, is that whole organisation approach. They worked really closely, engaging with infection prevention, engaging with clinical staff on the wards, engaging with their healthcare cleaners as well, ensuring that they did things as a group, looked at the policies, looked at what they needed to do, where they were going to risk rate their categories, looking at ensuring it was high on the agenda at the board, because that is the main thing. Cleaning shouldn't be that thing that tends to be item number 20 on the agenda when you only ever reach 18, because they're big agendas, we know that. Looking at those responsibility frameworks, working together, so actually everybody in the organisation understood their responsibilities. It's no good if we say, okay, porters have to clean all wheelchairs, that's their responsibility, but if you don't tell the porters that, they're not going to get cleaned. So it was about working through with everything. And they were actually early in implementing. Their date was the 1st of, or the date for people was the 4th of May, and they managed to implement fully with star ratings and cleanliness charters by the 1st of April. So a little bit about some of the lessons learned, and I will come back to this. One of the main things that people have always said is where they have great relationships across the hospital with clinical colleagues, with infection prevention, it works really smoothly. Where there's less engagement, it has been much more challenging, is what we're hearing. Doesn't mean they haven't done it, but it has been much more challenging. We know issues around COVID, and they haven't completely gone away. But that is about lessons learned from COVID as well. And there is in the standards guidance on what to do around any type of massive outbreak, whether that be a local one, a regional one, a national one, or an international one. So there is guidance on what to do. And these standards are designed for your every day. So this is day in, day out. If we got into another pandemic, again, we would be issuing guidance from the centre and support what it says in the document. So again, for some people, this journey was more difficult than others. Some trusts, I very naively came into this project in 2017 thinking, well, everyone will be compliant with 2007 standards, because when I was in a trust, that was the standard, and I wouldn't have dreamed of not meeting it. However, it did become apparent that some trusts were still on 2001 standards. Some trusts had some kind of hybrid of something in the middle. And some trusts, just had a contract that said, well, if you wouldn't mind keeping the hospital clean, that'd be great. So no kind of standard at all. So for some organisations, it's been a much longer road to become compliant, because we always base this that actually 2007, if you're compliant with that, the move across, yes, it involves some thinking, rethinking and looking at, but it's a fairly easy transition. But that hasn't been the case for everybody. But the great thing is there is lots of support there, and those trusts are working with us closely. They're working with their FM provider partners, and the FM provider partners are working with us as well. All of the standards that we do at the centre are very much linked together with a range of stakeholders. So, you know, for the cleaning standards, we had infection prevention colleagues, we had health and safety executive, we had our FM partners, we had a wealth of people representing from trusts and from other networks and professional associations. So for us, that joined up working is the only way we can do things from the centre, and it's the same in your organisations. Everything has to be joined up.